How's it going, guys? Difficult question. Cardiovascular step 1 surgery 2CK. 60-year-old woman undergoes angiography of the right femoral artery for peripheral vascular disease. 1 week later, there is a continuous machinery-like murmur at the angiography site. Vitals: temperature 98.6, heart rate 100, respiratory rate 12, blood pressure 130/90. Which the following most likely to develop in this patient? I'll talk about this image as we move through the clip. Choice A, ocular ischemia. Wrong fucking answer. So this could be two scenarios in USMLE. Could be a patient who has peripheral vascular disease where you have an atheroma, let's say in the femoral popliteal vessels that ruptures, causing a complete occlusion. Could also be atrial fibrillation where you have a left atrial mural thrombus launch off to femoral popliteal vessels. Wrong fucking answer. Choice B, cholesterol embolus. Wrong fucking answer. This is going to show up on USMLE where they show you a picture of a dude's foot with violaceous lesions all over it, and they're going to tell you he recently underwent a AAA repair. Implication being there's atheroma or atheromata that's launched off to the feet, causing the violaceous lesions. Wrong fucking answer. Choice C, high epicardiac failure. Correct answer. So that's a difficult clip. Not really, actually, because the only nebulous type of thing going on is this image where you say, I have no idea what I'm looking at. It's an AV fistula. But here's the catch. You don't need to know what you're even looking at in this image here. They don't expect you to be a radiology expert. It's obvious based on the vignette that you had an angiography, you had an intervention, and now you have a continuous murmur. Some of you are like, OMG, isn't that PDA? Take it up with NBME because they've said continuous machinery-like murmur for AV fistulae, okay? And they can also say to and fro. If you've been following my content, I've said both PDA and AV fistulae. Any continuous is synonymous with to -and -FRO, okay? So you have an AV fistula, and you need to know that AV fistulae are a risk factor for high output cardiac failure. You've got blood quickly leaving the arterial circulation for the venous circulation, and that's going to lead to more venous return. And you're going to have an ejection fraction that's initially increased, normally 55 to 70. They can tell you in the question it's 70. And there's dyspnea, implying the left heart is starting to decompensate. And they can say there's a combination of an S3 and an S4 heart sound at the same time. If you've gone through my cardio PDF, I've talked about how they give that combo sometimes, weirdly enough, as indicative of high output cardiac failure. Okay, you can see in Paget disease as well, not just iatrogenic intervention, but very buzzy, very easy. But for some of you, I know this is probably difficult. Real quick, choice D, spontaneous reclosure of ductus arteriosus. Clearly wrong fucking answer, okay? I mean, I don't really know what to say. Obviously, a PDA will be described as continuous machinery-like murmur to and fro, pansystolic, pandiastolic. This is going to be congenital rubella syndrome. Those are the neonates who classically get PDA. Choice D, wrong fucking answer. Choice C, systolic dysfunction. Wrong fucking answer. So as I already talked about, you get high output cardiac failure. So it's not considered systolic dysfunction. The heart has the ability to pump. You're not going to have low ejection fraction initially, okay? So as the heart decompensates and ejection fraction falls, it's considered high output cardiac failure. That's the diagnosis. So I've seen NBME questions 2CK level where they'll list these two side by side, and the answer is still going to be high output cardiac failure. But systolic dysfunction could reflect dilated cardiomyopathy, S3 heart sound. Choice C, wrong fucking answer. You know the deal. To make more content, if you like my style, subscribe my channel. Appreciate your time. That's it.